and trying something new behind me here, this green screen. We'll see how that works. Regrettably, my office at home has morning light coming through the back where my desk is. So I'm trying to get rid of some of that light because it's not the best, but we'll see how this works. So today, got an interesting topic, and that is what I call the final go, no-go decision for any medical procedure, whether it's a PICL or something else. And that is, when you go into a physician's office for a procedure or a hospital or a surgery center, there's that final decision that has to be made. Is this person up for this particular procedure today? Now, some of that information can be gathered on the back end during a telemedicine, but some of it is going to come down to the actual procedure day. So physicians do their best to make sure that someone is a candidate beforehand for the procedure, but things change or they can't get all the information they need. Hence, there has to be that final go, no-go decision. So we're going to talk about that today and answer questions as usual. Again, this is a new time format. We're on Sunday mornings now, trying to increase the engagement, give more people an opportunity for more live questions. So let me go ahead and share my screen here. And then we will get started. So again, today we're going to be talking about that final go, no-go office visit and what that means. So basically, again, any medical procedure has to have a final go, no-go visit where the doctor says, yes, you're healthy enough to proceed with this, or no, I see some potential problems here. Now, the goal is obviously to try to get the vast majority of that worked out beforehand, but it's not always possible to do that. So this particular discussion this morning was started by a patient that I had in the last week or two. Patient had driven, or the patient's family had driven 20 hours. In the telemedicine with me, not much about the patient's disability was discussed. Then they started discussing some of that with non-medically trained scheduling staff. And ultimately, I took the very unusual step, probably only done this a couple times on a PICL procedure, where I had to cancel the procedure because of some of the things we'll talk about today. So that brought up this discussion, right? Even though it's extremely rare, it's important to understand this final go, no-go decision and what goes into it. So again, like, comment, share, subscribe, because that's how we get this information out there to more people. That's how we get more people on here asking more interesting questions. Remember, for this particular discussion and weekly discussion, the more diverse, interesting questions we get, the better. That's how we all learn. So I want you to do these things because these are the things that drive engagement. These are the things that lets YouTube or Facebook know that, this is interesting content that people might want to see, and it helps other patients. So, we often qualify patients for a PICL procedure based on a telemedicine visit. Obviously, there's lots of information we gather. I think we've got now a 13-page information form that the patient has to fill out. Oftentimes, they're filling out a pre-telemed form where we're just trying to determine, is this person even in the ballpark of being a candidate? And then they'll fill out a much more extensive 13-page form to try to see if they're a candidate. We'll review all the imaging. We'll discuss all that information with the patient, and then we'll make a decision. Yes, you're a candidate for either posterior injections or PICL, or no, you're not, or here's some more information we need that might qualify you or disqualify you for this procedure. Remember, these are not elective procedures that you can try just because you want to try them. These are procedures that you have to be medically qualified into. Very critical point there, because I think a lot of people, after interacting with the alternative healthcare system, they're basically being offered things that are more elective, right? You can try this treatment protocol or try that treatment protocol. So they're not really used to being medically qualified or disqualified from a procedure. So to determine candidacy for, let's say, PICL, or whether someone has symptomatic craniocervical instability, we look for a cause. And that's trauma or hypermobility. We do not consider mold. We do not consider Lyme disease as possible causes for craniocervical instability at this point, simply because we don't have much data showing that those illnesses lead to this problem. That could change as time goes on, as more information is put together, but right now we don't have a lot of information concerning that. Symptoms, and we're looking here for kind of typical symptoms: headache, neck pain, pain that localizes to this area, dizziness, imbalance, other autonomic problems, things that most craniocervical instability patients report. Now, again, doesn't have to be 100% there, right? Meaning that it's certainly possible to have the problem, craniocervical instability, in an atypical symptom presentation. We're also looking for imaging, digital motion X-ray, upright MRI, reflection extension, et cetera, so that we can try to say, yes, this looks like craniocervical instability on movement-based imaging. Again, remember, we're going to always give preference to movement-based imaging. One of the things we don't do is ever make a craniocervical instability diagnosis solely on the appearance of ligaments on a static MRI. We want to have those ligaments challenged and tested to see if they're functioning normally on a movement-based MRI. And then finally, response to treatment, physical therapy, upper cervical chiropractic, wearing a collar, etc. And then there's that no-go or that go, no-go decision, which is exam. And I can't do an exam online. That has to be in the office. So we have to spend some time with the person. I've got to do a hands-on exam. We need to look at all the other intangibles that are very hard to get over telemedicine, and make sure that that patient's condition is consistent with outpatient care. Make sure that the exam looks like craniocervical instability. And that means that your candidacy for really any procedure, but certainly this one as well, isn't confirmed until you're seen in Colorado and you get a hands-on exam. Now, the good news is that we're pretty good at qualifying patients, right? About 10% of the time, we'll switch from a PICL to a posterior injection. About 90% of the time, we're proceeding as planned. And much less than 1% of the time are we canceling any procedure. That's about 1 in 300 cases, meaning I've done it just a handful of times because I didn't think this patient before me usually is a candidate for outpatient care. And that's a critical component, right? The PICL that we offer is outpatient. That means that you come into an outpatient clinic, you get what you need with regard to the evaluation. We review all of that. You get your procedure, you're in recovery, and you get discharged to home or a hotel room, etc. So we have to make sure that that patient's health and overall condition is consistent with that type of outpatient care, meaning you're not getting admitted into the hospital after this procedure like you would if you had an upper cervical fusion, for example. So what are examples of problems that are incompatible with a PICL procedure, for example? Well, one could be severe disability where we just can't position the patient correctly. Now, we've had some of this where we've been able to work around it, right? Patient really can't be turned. They don't do well prone. So we've stuck with just a PICL procedure with the patient lying on their back supine. So from that standpoint, we can sometimes work around it. But if we've got a patient where we have doubts that they can maintain that supine position and stay still because they spend their time lying on their side, curled up like a ball all day, and they might have contractures, etc., then we're starting to see a mismatch between outpatient care and this procedure. Number two, concerns about maintaining a peripheral IV. Had a patient with decorticate posturing like this. Very hard to get the arms out like this. Now, we can start an IV back here, but if you hold your arms like this, the IV is not going to be great. We can start an IV in here, but again, that's not going to work if you're holding your arms like this. There are central lines, but central lines and procedures done through a central line, meaning starting a central line solely for an outpatient procedure is not a thing. So that's another potential issue, concerns about maintaining that peripheral IV. Then number three, medical conditions that are inconsistent with outpatient care. Let's say someone has a pretty severe cardiac diagnosis or a pretty severe concomitant pulmonary diagnosis, or like a patient I saw this week for telemedicine, multiple medical conditions that are inconsistent with being treated as an outpatient. And then last common one, and there are others not on this list, would be uncontrolled severe pain before a procedure. And that is a patient with 10 out of 10 pain, nothing's controlling their pain. Hence, if we increase their pain through a normal flare-up after a procedure like this, it's not going to be controllable on an outpatient basis. So one of the things I can certainly tell you is if you really want to make sure of this, discuss any potential issues with the doctor on the telemedicine. Our scheduling staff is astute. They're great. My scheduler is actually has Army medical training, but they're not physicians. So if you fail to discuss something with the doctor and you're just discussing it with a non-physician scheduler, that could be a potential issue. So if you have any questions, make sure that the scheduler is looping in the doctor and you push those questions up the chain of command. And what I mean here are questions that about what might disqualify you. I don't know if my loved one, son, daughter, myself, I don't know if I'm capable of staying in this position for this amount of time, for example. If you're not getting anything from the scheduling level, then push that up the chain of command, get it seen by the doctor, and the doctor can help make that decision. So we try very hard to ensure that we know everything we can during a telemedicine visit. However, there's really no substitute for meeting with the doctor face-to-face and going through a thorough exam and trying to make sure you're a candidate, whether you're a candidate for this procedure or any other procedure. This is pretty common in medicine. Okay, I think that's all I've got. Remember, like, comment, share, subscribe. That's how we get this information out to more people. Let me go to answer questions here now. It looks like we got a whole bunch of them. So let's start from the top. Jessica, will posterior PRP C2 to C7 do anything for upper cervical instability? No, will not help in my experience instability that lives at 0-1 or 1-2, or at least most types of instability that live there. Now, if you've got a type 3A CCI where 2 is moving forward on 3 in flexion, then that's something that posterior PRP can help with. But in general, most types of hypercervical instability, the kinds that we generally see, type 2B, 1C, 1A, are not going to be helped by C2 through C7 posterior injections. Jessica, does physical therapy do anything for upper cervical instability? And do you have to get a DMX to get diagnosed with upper cervical instability? Listen, we always recommend that patients try conservative care prior to any type of injection-based care. So we have patients that respond well to physical therapy. However, most of our craniocervical instability patients do not respond so well to physical therapy. And as far as getting diagnosed, I always tell patients it's just about likelihood of diagnosis based on a diagnostic test. DMX is the most likely to show instability if present. Then comes upright flexion extension MRI as a number 2. Now, there are types of instability that I can see on an upright MRI that I can't see on a DMX, and vice versa. But when it comes to the types of patients we see, if you had to place your bet on one type of imaging showing instability if it were present, DMX is where you'd put your money. John Hank, if a patient has scoliosis that cannot be corrected and only get short-term relief from procedures like PICL, you're willing to treat them periodically, or have they turned away due to risk? No, John, I think that's all within the realm of possibility. A lot depends on how well the procedure responds and whether or not we can do anything to try to stabilize the scoliosis. So lots of different questions floating around there, but as an absolute, the answer to that question is we can usually treat that patient population. Regenix, mid-advanced by John Gardner. Can injecting V cells in the cervical spine help with instability in a disc bulge? Thanks. No, V cells really aren't a thing, meaning that I know you've got a couple people online advertising that they're using V cells. We've had pretty good research that shows that V cells probably don't exist. And a bigger concern would be the kind of clinics that would claim they're using V cells are not the kind of clinics that would be credible in being able to place cells into, for instance, cervical discs. So that's a very important distinction there to make, that 99% of the clinics that are advertising stuff like this on Facebook do not have the expertise to place cells where they need to go. And that's a big, big problem, whether you're injecting PRP into that area, you're injecting bone marrow, V cells, or whatever they think that is, where the stuff is being placed, how the stuff is being placed, how accurately it's being placed, who's doing the injection, what their training is, where is that injection occurring, what types of guidance are being used, are all critical questions to be answered. And based on what I see on Facebook advertising, 99% of the clinics advertising things like this would fail those tests at one or more points along the way. Elvin, trigger points in SCM give the same symptoms as CCI, and if so, how do you tell them apart? Is it common to have both CCI and trigger points in SCM? Elving, sternocleidomastoid muscles, these ones up front, just so that everyone can understand what we're talking about, are critical. They're critical movers of C1, C2 and the upper cervical spine. So about half of your rotation happens at C1, C2, about half of your rotation happens lower. And the sternocleidomastoid muscles are prime movers for that rotation of your head on your neck. Now, many years ago, in the days of the early NASA space flight program, they knew that astronauts were going to be exposed to high levels of acceleration. They knew that the sternocleidomastoids might get injured. So they did an experiment that you really couldn't do today, but it flew back then. And that was, they took primates, monkeys, and they cut their sternocleidomastoids to see what would happen. And the monkeys bounced into walls, meaning that the monkeys lost balance. So yes, trigger points to sternocleidomastoid can cause balance issues. They can cause a headache type pattern. So you would want to, for instance, have someone treat those trigger points in the sternocleidomastoid. That's a very simple thing to do. You can even try deep myofascial release of those to see if your symptoms go away. If your symptoms don't go away, then those trigger points there are probably secondary to Another problem, that could be upper cervical injury, or that could be upper cervical instability. Jessica, why some days does your symptoms seem to worsen, like with one movement, bounce off bobblehead, then a few weeks later seem better? Yeah, I mean, that's sort of the nature of instability, Jessica, meaning that it's not necessarily constant, and a lot of it depends on what it is you're doing. So, for example, let me give you a much simpler thing to think about. I hurt my ankle ligaments many years ago. They're now fine. I've had them treated since, but before I knew how to treat them, this was 20, 25 years ago, longer than that, maybe even. I would notice that my ankle pain would go up and down, and it was really based on my activity. My ankle was unstable. If I did more activity, I'd pay for it a couple hours later, and I'd be limping around. Now, that's a pretty simple one, right? I could say, if I do A, B, and C, I know that's too much for my ankle, and I'm going to spend the afternoon limping around if I do that in the morning. For your neck, a little bit more complex. Lots of things can get irritated. Nerves can get irritated. Joints can get irritated. Any of those can cause these symptoms. Elving, does CCI often create inflammation on nerves, and can you see inflammation on an MRI without contrast? Elving, CCI can create inflammation around lots of different nerves. The superficial cervical plexus, we've noted, the lesser occipital nerve, the greater occipital nerve, the third occipital nerve, to name a few, the C2 dorsal ganglion as well. And in general, you can't see that inflammation on an MRI without contrast. Now, there are some specialized MRIs called MR neurography, where that kind of inflammation can be tracked a little better, or pressure on those nerves can be tracked a little better. But that's a highly specialized image that has to be read by a highly specialized radiologist who knows to look along each nerve course. Stephen, can indication of VBI or any impingement of the vertebral artery be shown on CT, MRI, or DMX? Well, MRI and DMX would not be great ways to see that. You could do a CT angiogram, but usually it's with motion. So a CT angiogram with motion, meaning the artery usually gets impinged with motion. So you'd have to have the CT done with motion, an angiogram done at the right second with that motion in order to see the impingement. So the answer is it's pretty hard to do with imaging. You could get an MRA, an MR angiogram, but again, the problem there is the acquisition time is long. And so you're not going to be able to put that person in to a situation for a couple of minutes, for example, that might cause them to pass out. So those are all difficult things to find on really any imaging. You could try to use ultrasound, but ultrasound is very operator dependent, unlike MRI or CT scan. So your likelihood of finding that or not finding that really depends on the skill of the person holding the ultrasound probe. And even then, there are times when even a skilled person is not going to be able to see it. Regenix, it's been advanced by Oleg Churchin. I must surely have mild to moderate CCI, but no formal diagnosis. I'm getting evals of my condition now, including for tethered cord, so not ready for PICL yet, but really want a diagnostic and clear picture of the situation with cervical spine, so I know the full scope of what I'm dealing with. I don't want to do extra DMX radiation if I don't get a procedure soon after the first one. How would you recommend I get a CCI diagnosis and full picture in the meantime? Not sure what's being asked, meaning it sounds like you maybe had one DMX and you're getting a second. Listen, DMX is a good one to get. It's a fraction of the radiation exposure of a CT scan, for example. And then the only thing I can tell you is starting with a DMX or upright MRI with flexion and extension are good places to start. Then you could certainly get on in a telemedicine eval, looking at your total history to try to see if you likely have craniocervical instability that's symptomatic. As I've told many people, I'd be very, very careful with an occult tethered cord diagnosis. I think we know enough about occult tethered cord at this point scientifically to be dangerous as doctors, meaning that we're not quite sure what that is as doctors, and cutting the spinal cord is a permanent change to the biomechanics of the central nervous system and is much, much more invasive than something like a PICL procedure. So be very careful with that. You may want to watch some of the videos that are out there on that. Stephen, your thoughts on any nerve meds for severe CCI, such as gabapentin or anything for the nerves, calming overactive nerve activity flare? Yeah, of the nerve meds out there, Lyrica, pregabalin seems to work the best. It's the only one that's on indication for chronic nerve pain. So in my experience, Lyrica tends to be the most reliable of those nerve meds. John, should maximal cervical flexion be avoided after a PICL? Could it disrupt healing and re-injure things? I think you need to live your life as you normally would, within reason, after that kind of procedure. Now, most of my patients sort of live in a little box anyway, right? They figure out pretty quickly, if I do this, then I get symptoms. They don't do that. And they create that little box in which they live to manage their symptoms. I would recommend that you stay within that, meaning activity is tolerated, for that first 6 to 12 weeks after any kind of ligament procedure. I don't think you need to wear a collar. I don't think you need to have specific do's and don'ts about what it is you do and don't do, like specifically no cervical flexion. Having said that, if cervical flexion usually flares that person up, then I will expect that they don't do it for that first 6 to 12 weeks after that kind of procedure. Athena, patients appreciate sharing the clinical outcomes of adverse consequences. For example, are Lyme MSIDS patients at greater risk of adverse consequences? Explanations of this by specialists is useful. We don't see any difference in patients that come in with a Lyme diagnosis or a mold diagnosis at all in the patients that I see, and I'm agnostic about it. I don't really have a position one way or the other on any of those diagnoses. So the answer to your question is no, I don't see differences in adverse consequences in that patient population. Now, one of the things I will say is that if you're looking for a patient population that responds the most promptly to something like a PICL procedure, it would be an acute traumatic injury within that first 12 to 18 months. And as I've said, I don't know, more times than I can count, those are the patients that are usually a single procedure and done, meaning they have a single PICL procedure and then they are completely done after that. Then there's sort of everyone else, which includes people who have had this for a longer period of time that was traumatic, which includes people that have these alternative health diagnoses like Lyme, et cetera. So they're all in that same bucket. Regenetics been advanced by Sherry Scott. Is there a connection between healing and usually fast? Any supplements we can be taking in advance of PICL procedure and that we should avoid? Sherry, not that we have seen. We've got some supplements we like patients to take because they help to control chronic inflammation, and chronic inflammation is a problem for everybody. Well, not everybody, but most people these days, meaning that's metabolic syndrome, what we see Americans have in general. But as far as taking one specific supplement over the other and having some sort of rapid recovery, no, I don't see any credible evidence of that right now. AT, how much of a positive impact can exercise like cardio make in orthobiologic procedures like PICL in the first months of healing, assuming the patient can tolerate? Is there research on this? No real research on it at this juncture, but I would say that I think that's a good recommendation, and I call that threading the needle. And that means that in really recovering from any procedure, I think we can take a big lesson from watching how animals heal, right? Your dog goes and gets a surgery. They come back with a cone of shame, for example, and then they go down hard for a couple of days. But after that, they're kind of up doing things as they're able. And, they live within that little box for the first week or two. There's some things they can do, some things they can't do. They listen to their body. But as their body tells them they can do more, they're doing more. And that's what I call threading the needle. So by all means, if you can tolerate cardio after a procedure like this, maybe you could before, you should be doing that after, as long as that's not dramatically increasing your symptoms. So threading the needle between downtime to heal and uptime to heal appropriately is critical. And you're going to want to make sure you do that threading the needle by listening to what your body is telling you can and can't do. Elvin, how does stress affect CCI patients and their symptoms? Are there symptoms that get worse, etc.? I think stress tends to increase the tightness of all these muscles up here for a lot of people. And for CCI patients, many of the nerves that wind their way through those muscles are already sort of on fire. So they're more likely to get increased symptoms when that muscle tension increases. John, is baby aspirin 81 milligrams fine before and after orthobiologics? John, a lot really depends on the risk benefit of that. Meaning that if you're on a baby aspirin because you've had a cardiac event, then you'd want to stay on a baby aspirin. I think the medically prescribed baby aspirin is probably not going to impact the procedure very much. Having said that, if you're on a baby aspirin just because you saw an ad someplace or someone said it was a good thing to do and you've never had a cardiac event, never had any cardiac problems, then you'd want to get off that baby aspirin, because I think the risk-benefit ratio goes upside down in talking about small amounts of excessive bleeding, etc. Andreas, do you consider fluoroquinolones a risk factor or cause for CCI? No, I don't. We don't have any data that fluoroquinolones destroy ligaments to the point of causing craniocervical instability at this point. Now, we do have pretty good evidence that fluoroquinolones can attack tendons and cause a rip-roaring tendinopathy. We've seen that in lots of patients. But as far as destroying upper cervical ligaments preferentially to cause craniocervical instability, we don't have any evidence that that happens. So no, we don't at this point. John, how severe is 3 millimeters of cervical instability at C1 as most of you've seen in your office? John, I need to know a little bit more about what kind of 3 millimeters we're talking about. Are we talking about 3 millimeters of atlantodental interspace separation and flexion? Are we talking about 3 millimeters of C1, C2 overhang and open mouth lateral bending? Are we talking about 3 millimeters of translation at C2, 3? So I need to know a little bit more about where that 3 millimeters is to comment. AT, with right suboccipital area that's offline, my AO doc with palpation says he feels a tender rope-like tendinous nodule, likely from injury to the area. Is this something you've observed in your patients? You can certainly feel tight. Certainly sounds like tendon or muscle in that area. Maybe that's the rectus capitis posterior minor, for example. So sometimes we can feel that get very tight. Maybe that's an inflamed nerve, like an occipital nerve. Hard to know. I'd have to palpate it myself. Regenix, been advanced by Harry Winston. What is the average wait time between scheduling a PICL and the procedure takes place? Harry, that really depends. Could be anywhere from as short as a few weeks to as long as a few months. When patients have an acute need, we usually put them on a cancellation list so that they can get in more quickly. It also depends on the time of year. Certain times of year are more popular for patients. For example, back to school time, we tend to see a reduction in people coming out because they've got other things to do if they have kids, etc. Stephen, with current EPICL, currently what percent of patients would say only require one procedure when you say 7 and 10 as a success? Is that saying success stability shown on DMX or success in symptom relief? And if so, all symptom relief, thank you. So I don't know what the current numbers are for EPICL because we're only about 4.5 months into that one at this point. But when it comes to all PICLs, the ones that usually require a single procedure, as I said before, are those patients who are acutely injured, let's say in a car crash. They can point to, yes, that's the day I got injured. They have typical CCI symptoms. They're within that first 12 to 18 months of being injured. So those are the patients that are usually a single procedure. As far as 7 and 10 success rate, that's in symptoms and patients deciding that they've gotten enough relief from this that they're not pursuing any other care. So that could be anything from I'm completely symptom-free to I'm mostly symptom-free to I still have symptoms and I still have to live within the box, but the box is much bigger than it used to be and I can live like this. AT, although shockwave therapy does nothing for intrinsic ligaments, can it help in cases of more superficial injury of the suboccipital area, maybe simulating the muscles online? I don't think anyone really knows that. I would say that shockwave therapy, or at least trying shockwave therapy for those muscles, might be okay. The only thing I'd be concerned about is that the occipital nerves are right here in the midline, third occipital nerve. And as you come out a little bit, greater occipital nerve. Then as you come out a little bit more, lesser occipital nerve. So you wouldn't want to piss those nerves off with shockwave. That would be my only concern because then you're going to worsen your headaches. Daryl, regarding last week's topic, I have CCI transverse ligament laxity. I have PICL number 1 back in March, number 2 scheduled in August. I have both AC separated shoulders or anything surgical or regenerative to help with shoulder stability that could also help with CCI. Yeah, Daryl. So we often see that, and if the patient can tolerate it, we will usually treat those ligaments. Now, it's possible that you have a huge separation where there are no ligaments left to treat, but for 95% of the patients we see, we can stabilize those AC joints by adding that to the list of things to be injected. Robert, does a fusion, fluid or adipose in the joint cause a negative healing potential with regeneration? Is it also between tissue planes? Usually when we're talking about a fusion, it's not adipose, it's only fluid. So a fusion by definition would mean extra fluid, usually in a joint, or let's say around the tendon, for example. Is it a negative predictor? Not based on what I see. I gotta stop sharing my screen. Sorry about that, guys. Not based on what I see. No, I don't think it's a negative predictor. In some ways it's positive because we can know for sure, for example, that joint is a target. John, can CCI cause tightness and tenderness in the chest somehow? Many of our CCI patients have rib issues as well. You can call it slipping rib because many of our CCI patients have hypermobility. Sometimes our CCI patients have had a car crash that has damaged some of the fascial covering around the ribs or damaged the ligaments or the ribs attached to the sternum or the thoracic spine. So it's usually happening kind of side by side with a separate set of issues happening in the thoracic spine and ribs. Lanaya, hey Dr. C, since having CCI, I've noticed a lot of extra fullness accumulate under my chin, but haven't gained weight anywhere else. Could this be CCI related? That area feels very full and the muscles around it feel tight. My PT thinks it's lymph fluid that can't drain properly. It looks like a double chin to me. love to learn more about how CCI might impact that area. Lanaya, one of the things we see in a lot of our CCI patients, and just a lot of patients in general these days, is because they do this all day with their phone, they are creating a postural issue that pushes the head forward, which then increases this underneath here. Now, is it also possible that you're getting overload of the anterior strap musculature? That's also common in CCI. So we'll see patients who get very tight in their temporalis, through their TMJ, through the omohyoid, myohyoid, all of these muscles in here as well, because they're using that anterior strap musculature to try to stabilize their head. And that could cause some changes in lymph flow as the lymph goes through those muscles. So it's certainly possible that what your physical therapist is describing is true, but I also encourage you to see if you've had changes in posture that could also cause that, because that's not uncommon as well. Stephen, I'm currently diagnosed with CCI-AI cervical spondylosis from Josh Goodwin in Las Vegas. He's a great doctor and currently our plan is posterior pillar for a minimum of 3 sessions to see if I get any symptom relief. Your thoughts? I think I may need to be referred to you or scheduled 10 minutes, and I have a 6.2 overhang to the right with alar and transverse ligament damage indicated by that overhang. Yeah, so that would be what we would call a CCI type 2B. Normally, posterior injections won't work in a CCI type 2B because those posterior injections don't have, those posterior ligaments don't have enough leverage on that type of side-to-side motion at C1, C2. Do I think it's a net negative to try some simple prolo? No, it's not. But I don't think it has a high success rate either based on my experience. Harsh, does BMAC 24 hours post prolotherapy kill all the stem cells like in the knee? So BMAC 24 hours after prolo? No. So I think what you're talking about is that we had some providers around the country that hadn't done really any in vitro research in this area that were using bone marrow concentrate with live stem cells, autologous from that person, with a prolotherapy injection at the same time. We did that research many years ago in the lab, looking at various concentrations of prolotherapy, seeing that prolotherapy solution killed the stem cells quite dead. Now, when you inject a prolotherapy solution into the body, you'll get an immediate osmolar shock where you'll get some local cell death, kind of like a little debridement of the area or debriding a wound. But you'll also see that osmolar difference get neutralized out pretty quickly by the body. So a prolo injection separated by 24 hours and a bone marrow injection shouldn't impact the bone marrow stem cells because the body has already neutralized that osmolarity, meaning the concentration of the fluids in that area. And if you're going to do that, usually you put a couple days between the two because you want the prolotherapy to do an acute inflammatory reaction, and then the cells hit the ground running at around day 3 or 4 after the prolotherapy. Andreas, can sympathetic trunk irritation, in addition to vagus nerve irritation, contribute to symptoms? In regards to that, what is your opinion on stellate or superior cervical ganglion blocks for relief? Yeah, so it's possible to get irritation with craniocervical instability. I think that's what you're talking about, Andreas. Correct me if I'm wrong. And then that can contribute to symptoms. Certainly stellate or superior cervical ganglion blocks, really stellate ganglion blocks, can provide relief for PTSD type symptoms. Again, I think it's all a risk-benefit equation, right? We need to look at what the risk is of that procedure, which is fairly high in the scheme of things, meaning that's a riskier procedure than a cervical discogram, for example. Probably a riskier procedure than a PICL as well. And then Obviously, if we need that kind of treatment, then we look at the risk benefit of applying that kind of treatment. Stephen, your thoughts on Regenexx Clinic doing posterior prolo from C1 on facet joints and ligaments. Again, Stephen, I think as I always say, when it comes to C0, C1, C1, C2 facet injections, only Colorado in our Regenexx network is qualified to do those procedures. I don't recommend any outside clinics to do those procedures. When it comes to doing just sort of ligaments there, I think that's just fine. That's fairly easy to do. If it's done with imaging guidance, fairly safe to do. Elving, is it common to get extreme fatigue in the shoulders, trapezius levator, before getting a headache if you have CCI or occipital neuralgia? Yeah, I think what you're describing, Elving, is that we'll often see that the local suboccipital muscles go offline in those patients. And by them going offline, the big muscles then take over: scalenes, levator scap, upper trap, etc. And then some of those muscles, like for instance the upper trap, can irritate things like the occipital nerve and then give a headache. Linda, first, can CCI, if left untreated, cause instability down in the upper thoracic spine, ending up with thoracic spine instability? Second, can CCI lead to or contribute to thoracic outlet? Third, can CCI lead to POTS and pass out, scoping to the ground? Let's see, the first one. Can CCI lead to instability in the upper thoracic spine? Probably not, but it can certainly cause patients to have problems there. Second, can CCI lead or contribute to a thoracic outlet? Yep, we see that one all the time. Usually it's through the scalenes, because the scalenes are trying to stabilize the upper cervical spine. They get tight. The nerves through the thoracic outlet go through those scalenes, because the scalenes are the walls of the thoracic outlet, and then they get thoracic outlet syndrome. And third, can CCI lead to POTS? We've certainly seen CCI patients with POTS-like symptoms, usually due to vagus nerve irritation, and then that goes away once we treat the CCI. Now, having said that, it's important to realize that not all POTS is caused by CCI. So if your only symptom is POTS, and you happen to have a little CCI in your imaging, I'm going to be pretty skeptical that that you have CCI causing your POTS until proven otherwise, simply because there usually has to be other things going on, like a headache, neck pain, etc., for there to be a credible diagnosis of craniocervical instability or symptomatic craniocervical instability. Zigzag, is a fool's errand to attempt curve correction before treating ligament instability if present? Do muscles maintain the natural cervical curve, or is the integrity of the ligaments themselves? No, I think, Zigzag, in talking to curve restoration providers, what they will tell you is that if they can get that curve back, then we can offload areas like the upper cervical spine and hopefully give them a chance to heal naturally. Now, is that going to work well if someone is really unstable in their upper cervical spine? No. Frequently, those patients declare themselves as not being able to tolerate curve restoration. Brian, what percentage of BMAC is stem cells? Less than 1%. If we're talking about CD3/4s, we're talking about mesenchymal stem cells, all the other type of progenitor cells in there, no, it'd be much more than 1%. So the answer to that one. Andreas, can CCI cause changes to the blood-brain barrier or other metabolic changes in the brain? If so, can this be tested? I don't see any evidence that we have that CCI causes changes to the blood-brain barrier or other metabolic changes in the brain. Now, those are all interesting areas for existing research, looking at things like cerebrospinal fluid flow and the long-term implications of disrupting cerebrospinal fluid flow. But we're just in our infancy in understanding how all of that stuff fits together. Stephen, I think many of us would like a video on success stories. Thank you for doing these lives and answering questions for us dealing with this terrible condition. Sure, Stephen. Yeah, it's funny. I've stayed away from that because I think it's a little hokey. We have lots of success stories. I see them every week. But we've had a bunch of requests for it, so I think we'll start doing it. Again, I've stayed away because I've seen some providers do this online, and I've always thought it's just super duper hokey. But we've had a bunch of requests, so we'll probably start doing it. In fact, I was just thinking about that this morning and who we were going to assign that task to. The other reason why I don't necessarily like it is we sort of do an iPhone in an office. Sometimes it looks like a hostage video. So we'll see how we try to pull that off, but we may start doing that just because we've had a bunch of requests for it. But I think it's important to note that I see patients every week that are great success stories. I do almost exclusively PICLs and upper cervical treatment now. So lots of great stories coming through every week. Obviously, I could be blogging on them. I could be getting videos, etc. So far, I've resisted that, but we may start doing some of that. Harsh, can small parts of the ACL that have flipped out of the stump present as intra-articular loose bodies in the knee? I mean, is it possible to get a loose body based on a completely torn fragment of the ACL? I think it's possible. Is it the most likely cause of a loose body in the knee? No, that's usually either pieces of cartilage or pieces of meniscus. Ashraf, hi, doctor. Thank you for your dedication to this. You're an incredible person. Thank you, Ashraf. How much volume of liquid was injected into the ligaments, and do you increase, decrease if required? Yeah, Ashraf, it really depends on the ligament and on the tolerance. So when we're injecting ligaments, we've got direct visualization of that ligament. So we can see how the ligament itself is accepting volume. So for example, let's take an easy one like an ACL, for example. Easy to see, easy for us to track how it's taking that up. In a tightly packed ACL ligament, you might only be able to get 1 cc into that ligament. In a loose packed mucoid ligament, it might accept 3 or 4 cc's. So that is determined by looking at the volume you're injecting, whether or not you're getting full coverage of that ligament, and then how is the ligament responding to that injection. Mark, I seem to have somewhat unusual healing response to PRP and stem cell treatments. From what I can tell, there's a small percentage of patients that do as well. They typically get worse for around 8 weeks after the procedure, and this typically continues until around 12 to 14 weeks. Is there any explanation for this? Also, after my previous stem cell treatment, I did not see the full benefit until around 12 to 14 months after post-treatment. I seem to be a very slow healer. Yeah, Mark, that's certainly possible. We have seen some patients like that, usually not 12 to 14 months, but some people that are way out, like 6 months, 8 months. I think some of that could be due to that fragile leg syndrome that I talk about, or central sensitization, meaning for some patients, their nerves are so much on fire that their flare response goes over the moon before it comes back down again, and they start feeling well. So that's usually what's causing something like that. But we have seen just slow healers for sure. Regenix, been advanced by Harry. Would you recommend having having whatever upper cervical procedures that Algocell has done before telemedicine with you for CCI? Harry, that's completely up to you. Certainly, those are good guys. I'd encourage you to visit with them, see what their assessment is, and they can give you a good idea of how to proceed from their end. I think they're very competent providers that are not going to do anything they're not comfortable with. Zigzag, what's the difference between PRP and PRF? Can't they both be injected in ligaments? Why use one over the other? PRF is platelet-rich fibrin. It gained popularity more from surgeons trying to use PRP because it's clot and it can be sewn into a spot. Now, it doesn't seem to be as effective as PRP, at least in the surgical studies, and a lot of that is probably because it's a clot and it's not going to do much in a certain area other than sort of release some growth factors. So unlike PRP, where you can inject it, for example, in a ligament, it'll spread throughout the ligament. You can't do that with PRF because it's already clotted. Lanaya, my recent PICL, we weren't able to treat above the atlas because my airway was too tight, extra weight and tonsil inflammation. Can you talk more about how that works, and does the below atlas approach affect likelihood of success? I guess the good news, Lanaya, is for many years, all we did was below atlas, and we were having pretty good success. But I do think you bring up an important point, and that is at the end of the day, just realize that the status of the airway can make a difference in what we can accomplish. And what Lanaya is talking about is that if you carry a lot of extra weight, that's going to put pressure on the inside of the airway and on your tongue to move up. So that's going to constrict or make your airway smaller. Now, for some people, because they're born with a big airway, it has less effect than in other people because they're born with a smaller airway. Then we add CCI into that, where there may be some shifts that are occurring, which is reducing airway size. And then we can add tonsillar inflammation into that, where some people just have chronically swollen tonsils, and that constricts the airway more. So this isn't a universal thing, but if we see that, and it is making it harder for us to do the procedure and increasing the risk of your procedure, then we'll let you know about it, and we'll want you to try to lose some weight, because that's the surefire way to try to make this whole thing easier and to reduce the risk. But just realize that it's not everybody, right? We see heavy people whose airways are easier to manage, and some patients who are heavier whose airways are a nightmare to manage. All being heavy does it just increases the risk that you're going to have an airway problem. If we see someone who's really thin, usually their airway is fine, but sometimes we'll see a thin person with a bad airway as well. Being thin just lowers your risk of having an airway problem. So those are some things to think about. Athena, for CCI patients who are unable to seek care post-MVA, is a general approach of stem cells useful? And what is the duration of life of maybe injection? I don't know what we're talking about there, Athena, what diagnoses we're talking about. So hard to answer that question as phrased. Ashraf, can you do prolothoracic at the same time as PICL, either with dextrose or stem cell? And if stem cell, would you be able to extract enough bone marrow for it? Yeah, Ashraf, we do that all the time. We'll treat thoracic issues if they're present. If we have enough bone marrow, we'll use it for that. If not, we'll use either a platelet-based product or prolotherapy, depending on what it is we're trying to treat. But as long as the patient can tolerate it, we do that all the time. Robert, how long is one under anesthesia propofol for EPICL? Yeah, Robert, I would say for my patients, we're looking at as little as 35 minutes to as long as an hour and a half. I would say most patients would be 45 to 50 minutes under that type of anesthesia in that kind of procedure. Now, I tend to be the fastest at doing these procedures just because I do the most of them. And obviously you gain efficiencies as you start to do more and more of something. Your accuracy goes up, your efficiency goes up, procedure times go down. That's a good thing, because the least amount of anesthesia we can use, the better. Athena, for longstanding CCI patients with a history of trauma, are stem cell injections useful? What is the life duration of injections? How often is it required to maintain? Patients just 2 years. Yeah, I don't really see that, meaning the patients that we've had from early on that got treated and are doing well aren't popping back up on the radar a couple of years later at this juncture. So I don't really see that if we're talking about something like a PICL procedure. Now, if we're talking about something like knee osteoarthritis, then we tend to get 2 to 5 years, sometimes 2 to 7 years of relief, but that's a different type of pathophysiology. Kimmy, I had my 4-month follow-up a week or so ago, and Ryder recommended new DMX since I haven't shown a lot of progress. What I've talked about with the patients, 4 months is pretty early to see improvements. Asked if I could reevaluate 6-month mark. Do you still think I require another DMX? No, Kimmy, you can certainly push it out to 6 months to see how you do. Obviously, if you start to see some good benefits, then we don't necessarily need to repeat the DMX. I think the only reason he recommended a repeat DMX is he knows that's my protocol. So if someone is at that 4-month mark, they're not seeing much in the way of symptom change, and we're trying to see whether or not we're headed the right direction, we'll look for objective changes in the DMX to make sure of that. But there's nothing that says that you can't wait another 2 months to see how you might respond. Kimmy, I also just found out that I have mono, which I think is taking a toll on my feeling improvements. Is there anything I should recommend or recommend with mono 4 months post PICL? I declined steroids. No, I think you did the right thing by declining corticosteroid use. But in the meantime, not my area, treating mono is not my area of expertise. And again, the corticosteroids can have an impact on lots of different tissues. Now, if you had to use corticosteroids, 4 months is a heck of a lot better than using them at 2 weeks, for example, meaning that the healing is done by 4 months. We're in the remodeling phase. And if you're going to take corticosteroids at any time post an orthobiologic procedure, 4 months would be much better than 2 weeks. John, would re-injury of treated ligament have the same swelling and pain of a normal ligament? Not sure what you mean by that one, John. And guys, I'm coming to the hour here, so I'm going to try to see if I can clear out the questions I have on the table now. Hi, Centeno, can you please describe treatment for vertical instability? Yeah, Nikki, a lot depends on what we're talking about with vertical instability. If what you mean by vertical instability is that in flexion, your Bayesian, your BDI, Bayesian Dens Index, goes up, then that's something that a PICL procedure can handle, because the goal is to tighten those ligaments. So that would be this type of vertical instability. So an extension or flexion, the BDI is going up. Now, if what you're talking about is cranial settling, where there's not much room at all between the Bayesian and the Dens, and they're right up against each other, then PICL is probably not going to be the right treatment for you if that's what's causing your symptoms. Now, that would have to be an evaluation, right, of is that causing your symptoms or not? And there's really no surefire way for us to determine that, including invasive traction. Brian, my overhangs went from 6.7 to 3.9, 4.3 to 2.0, ADI, had 2 PICLs. It's been 3 months since last one. How long to decide on round 3? Yeah, so Brian, that really depends on your symptoms and how you're doing, meaning if at the end of the day you're still having substantial symptoms, then we would proceed with another one. If you're not, then we generally wouldn't. And then Elving said here, I don't know what that means. Okay, so I'm going to start to wrap up questions. I'll take 3 or 4 more, and then I'm going to get going with my weekend here. Adina, can CCI induce white matter lesions due to brain hypoxia? I don't see any evidence of that, Adina, at this point, no. Renee, this is a bit off subject. Do you have a procedure that can help fallen arches? Not so much fallen arches per se, but dealing with the consequences of fallen arches, yes, orthobiologic injections can be very helpful there. Marcia, thank you very much for the education you provide. You're helping people in mass as well as individually. Yeah, Marcia, that's why I do these, because again, the more people we get asking questions, the better. And also everyone learns a little something from, I think, people asking different questions. And it's also good for me as a doctor, right? Because sometimes I don't know what patients know and don't know. And that's why just letting them ask questions and let other patients listen to those answers helps everyone, because you might be saying, oh God, I have the same question as that guy. Athena, to your point, it would be more professional and comprehensive to include injured or not improved patients. Up to 30% are noted in your clinical outcome analysis 2 years ago. I don't know what that means. To your point, it would be more professional and comprehensive to include injured or not improved patients. I think that's what we've been doing, Athena. I'm not quite sure what your question is about or concerning there, meaning I think as we talked about, I've always talked about, the response rate for this procedure is about 70%. That means 30% are not responding. So I don't know what it is you're trying to get at there. Happy to answer questions here. I think your previous one was for CCI patients who are unable to seek care post-MVA. Is general approach to stem cells useful, and what duration and life of injection? So I don't know what that one has to do with that one, so not sure how to respond to that one. Zigzag, how do you identify which vertebrae is affected in slipping rib syndrome ultrasound? No, usually it's palpation. Sometimes you can see it on ultrasound with inspiration, expiration. We certainly use that from time to time, but a lot of times it's a palpation-related exam. Marcia or Marcia, do you have any recommendations for the type of neck bracelet to wear while riding in a car? Meaning a neck collar, I don't have any specific recommendations just because it's so wildly different between patients. For example, Miami J collars are great. They're very stiff, but for some of our patients, they put pressure on the wrong spots. So I often tell patients is, when all else fails, try a soft cervical collar, see how that goes. If you can tolerate a hard collar, that's fine. But again, this is just short-term use, because the more you use the collar, the worse things are going to get. And then you may need to cut down the collar in certain areas or add padding in certain areas to make the collar comfortable for you. Robert, do you do PICL first before posterior? Is the patient under anesthesia the whole time, or only PICL portion? Yes, and when we're doing a PICL, we start with a PICL, then we'll wake the person up, flip them over, put them back to sleep, and do the posterior. So they're asleep for both, but they're generally awake or partially awake for the transfer, because we like patients to be able to help in that. We think that keeps them much safer. Stephen, possible to have a 6.2 overhang on one side and on the other, or maybe a DMX report dimensional lifts up because what sniffing. Thanks. It is possible. Yep. Elving, thanks so much for all the replies. All respect to you. Thanks, Elving. Marcia, why do numerous neck braces aggravate my pain after 5 minutes of work time? I think that gets back to what we were talking about before, Marcia. At the end of the day, I think what happens to a lot of patients is they put pressure in specific spots. So here's a really common one, for example. The occipital nerves live back here, right? So if you've got a neck brace that puts pressure right there, that's going to cause that occipital nerve to get aggravated. So that's why I tell patients, you got to kind of try to find the right neck brace for you. You may have to try a couple, and you may have to cut some areas out, for example, because they're putting pressure. It's putting pressure in specific spots, which is then aggravating something else. John, does the honeymoon phase indicate treatment was successful? If you get injections in the C1 ligaments area and it feels great for the first week, does that essentially mean it's working in the right spot? John, I think the honeymoon is more helpful to know that we're headed in the right direction, but doesn't necessarily indicate success or non-success. Linda, Dr. Centeno. Yeah, my name's Centeno. There is a separate Dr. Schultz. Thank you so kindly for doing these live Q&A. I'll need to come see you. God bless you. Certainly happy to help. Corinne, super helpful. And guys, I think, well, I have a couple more. So let's stop our questions there if we could, because we're about 10 minutes over. And I'll try to get to the rest of these. Harsh, can you visualize intercostal nerves on ultrasound? I've got pain just below the bottom, most right rib, and it comes on suddenly when walking. Yes, you can visualize part of the occipital nerve, but the occipital nerve is under the rib margin, so it's not so easy to see with ultrasound. Brian, how long after PICL, if I'm not symptom improving, do I say go another 6 months, 3 months? Yeah, Brian, so usually we'll give patients 4 months. We do have a small subset of patients that then require a longer recovery than that, but most patients we give 4 months. Renee, happy to help. Harsh, doctor would be doing non-PICL procedures in the future. Thanks for your creating Regenix. Yeah, Harsh, I do non-PICL procedures now, just not a lot of them, meaning I've tried to focus my practice more on craniocervical instability, PICL, posterior injections, all of that kind of stuff. But I do those every day I'm in the clinic, probably. Marcia, thank you so much for the neck brace discussion. Satwinder, what is injected during PICL, PRP? That's bone marrow concentrate, platelet-rich plasma, high dose, leukocyte poor, and platelet lysate. And then last question, Monsef, thank you, doctor, for the response last week. Sorry for the off-topic question, but can degenerative discs in the neck improve over time? We've had several hundred discs with symptoms. You know, Monsef, I don't think we see evidence right now that they improve over time with injections, orthobiologic injections, but I think we can reduce the consequences of them. Having a degenerative disc is no big deal. It's like wrinkles on your face. It's pretty normal with aging. What we want to try to do is to reduce the consequences of that degenerative disc, the degenerative instability, the irritation of the spinal nerve, etc., because that's what people function all the time just fine with degenerative discs. It's the consequences of the degenerative disc that then cause problems and create disability. So guys, thanks so much for all the great questions today. I don't know how many I've gotten through, maybe, I don't know, a couple dozen, 50, 60, 70, 80, somewhere in there. Again, questions, I think, help patients learn. And you can almost consider these things like one big Q&A section on a website that's now thousands of questions deep. Because I try to do these as much as I can. Maybe we're getting through 35, 40 of these a year right now. So if you think about that, each one has at least 50 questions being answered. So you expand that out, and we're in the tens of thousands of questions answered now. And again, that's what this is all about, trying to get people together, trying to get engagement, trying to get questions answered, and also trying to provide a little kernel of information each time we do it. So that's why I try to give an upfront lecture. So I'll be doing this again a week from this Sunday. It does seem like Sundays are getting better engagement. Makes sense. People are not working, so they're more likely to jump on and engage. So thanks so much for your engagement and time. And you have a great week coming up, and I will be here, same bat time, same bat channel, coming up this Sunday, a week from today. Thanks so much.